A 68-year-old man presents with rapidly progressive dysphagia and weight loss. I am showing you barium esophagograms. Describe the findings.
Okay. The esophograms demonstrate moderate dilatation of the proximal and mid-esophagus containing retained secretions. The distal esophagus displays irregular asymmetric tapering at the gastroesophageal junction with nodular mucosal contours in the region of the gastric cardia.
What is your primary diagnosis?
The primary diagnosis is pseudoachalasia, secondary to an infiltrating malignancy at the gastroesophageal junction, most likely adenocarcinoma of the gastric cardia.
What is the key pathological difference between primary achalasia and pseudoachalasia?
Primary achalasia is an idiopathic loss of ganglion cells in the myenteric plexus, leading to failed lower esophageal sphincter relaxation. Pseudoachalasia is a secondary narrowing caused by direct tumor infiltration of the myenteric plexus or mechanical obstruction by a mass.
State 3 clinical or demographic clues that favor pseudoachalasia over primary achalasia.
Based on that, clues favoring pseudoachalasia include age greater than 60 years, rapid onset of symptoms of less than 6 months duration, and prominent rapid weight loss.
Identify 3 key fluoroscopic findings on a barium swallow that distinguish pseudoachalasia from primary achalasia.
Well, differentiating features include mucosal nodularity or ulceration in the narrowed segment, shouldering, or eccentricity of the tapered junction, and a narrowed segment that is longer than 3.5 centimeters.
Describe the pharmacologic test performed during fluoroscopy to differentiate the two and the expected results.
Okay, inhalation of amyl nitrite can be performed. In primary achalasia, it causes temporary relaxation of the lower esophageal sphincter and passage of barium, whereas in pseudoachalasia, there is no response due to rigid tumor infiltration.
Besides gastric cardia adenocarcinoma, what other malignancies can cause pseudoachalasia?
It can be caused by esophageal carcinoma or secondary metastatic infiltration from lung cancer, breast cancer, or lymphoma. Rarely, benign lesions like amyloidosis can also cause it.
What parasitic infection is a known cause of secondary achalasia, and where is it endemic?
Based on that, it is Chagas disease caused by Trypanosoma cruzi, which is endemic to Central and South America. It destroys the myenteric plexus throughout the GI tract, causing megaesophagus and megacolon.
Why might a screening upper endoscopy be falsely negative in pseudoachalasia?
Endoscopy can be falsely negative because pseudoachalasia is often caused by submucosal tumor infiltration beneath a normal-appearing mucosa, leading to negative superficial mucosal biopsies.
If endoscopy is negative but clinical suspicion remains high, what is the next diagnostic step?
The next steps include repeat deep endoscopic biopsies, endoscopic ultrasound to visualize the submucosa, and a contrast-enhanced CT of the chest and abdomen to evaluate for a gastric cardia mass or wall thickening.